Let's start. So thanks everybody for joining us today. We're going to talk about anatomy and radiology. And the first one to talk is our friend Bang Novik from Sweden. Um, we will learn about ventral anatomy. Please, Bang, when you're ready.
Unmute, Professor.
Yeah. Your audio.
Can you? I can't share. You disabled the screen sharing.
Try again,
we
please.
couldn't share the screen because I was going to show Conrad with a tie, but I couldn't.
See if you can share now. Okay.
Do you see the? Do you see it? See the screen?
It's okay.
Okay.
Yeah.
Very good. So I like to talk about about ventral anatomy, and I was told I couldn't show any radiographs, but I will try to do my best to go through. Doesn't it work here? Oh yeah, I'm sitting right here in Sweden. I have no disclosures. I would talk about different kinds of anatomy, microscopic surface anatomy, preperitoneal, and something about nerves, what I can do. This is my model. These are the most common sites for ventral hernias. But may I ask, how come a big guy like this who trains so hard do not develop hernias? It's obviously not due to how much how strong you use your body. It's something else. So this is biology, and I would like to show these microscopic pictures of connective tissue. Very nice pictures from, this is a non-hernia patient who they took the biopsy from the rectus sheath while doing the appendicectomy. Then they took from a hernia patient they took the same biopsy distant from the hernia repair, and it looks like this. And you can obviously see that there's a big difference. This is very poor quality in the connective tissue here. Now, on Arnold here, you can see the rectus muscles, the linea alba, the external oblique, which is the most superficial of the three lateral component muscles, and the linea semilunaris very obviously here. But also, I'd like to talk about the extraperitoneal space. So under these structures, there is fat, and it's not the same all around. So it's much in the midline in the rectus, space of retius, and on the lateral sides. So I was strictly ordered not to show any CAT scans, so I took this one instead to show this area here that is preperitoneal fat under the transversus dominus. But also here, this is a linea alba. But under the linea alba, there's a column of fat also, which is quite thick. A traditional description of hernia is you have a defect in the abdominal wall, and there comes a peritoneum that herniates and forms a hernia sac with bowel. But that's not really the case in ventral primary hernias. As an example, I show this small umbilical hernia cut horizontally. You will see here that this contains preperitoneal fat. And also, there is preperitoneal fat on the sides. It's actually this column of preperitoneal fat under the muscles. And also you can see here, which is correctly drawn, as a dimple. And that is the first case with these preperitoneal hernias that you may not even see it if you do a laparoscopy. There might be a dimple. When it evolves more, like now we move to the epigastric site, here comes the preperitoneal fat here, herniates up subcutaneously, and actually pulls its attached peritoneum, and then we have a hernia sac. So these are the epigastric and umbilical hernias. The Spigelian hernias have also these with a fat under. On this schematic drawing, we removed the rectus muscle and the outer lateral muscles to show this is the linea semilunaris, and between the linea semilunaris and the rectus sheath is the Spigelian aponeurosis, and this is a site for Spigelian hernias. They can occur anywhere here, but most commonly in the Spigelian belt. And they can look in all kinds of ways. And this pictures here, there's a peritoneum, transversus abdominis, the rectus, the internal oblique aponeurosis, external oblique aponeurosis, and the pre-peritoneal fat. And here are different variations of that, how it can look. There's those two aponeuroses are conjoint. Here they are separate. And here the hernia only goes through one of those layers. Here it goes through all layers. And we have the external oblique fascia only as the outer limitation of that hernia. And here's another variation of that, and here's a very unusual one. But in neither of these actual drawings is it correct. What I think is most common is actually pre-peritoneal fat that herniates too. And you can sometimes see very big, like mushrooms of fat here, which are difficult, maybe difficult to find if you don't suspect it when you do your operation. The flank hernias, just shortly, I understand David Laurier would probably show an amazing talk about this, but this is the path for the flank hernias. We have two triangles of interest. On this side, we have removed the latissimus dorsi. The upper limit here is a 12th rib. That's the important thing here. And they are more common on the left side. So this is a Greenfeld hernia on the left side. The inferior triangle, the triangle of Petit, has also bone structure. Here, the iliac crest as a limitation here. And as you see, the latissimus dorsi here. And on the side, it may look something like this. From the laparoscopic view, I found this drawing I think is nice. The patient is lying something like this. And here's the right colon, and here's the defect by mobilizing this. Turn down, this is just to see where it's close to the iliac crest. That's why I like that picture. So incisional hernias, if we have the incision here on the midline, as I told, the tension on the abdominal wall is sideways. So it's sideways until it might rupture here. And the gold standard operation is a Rives-Stoppa operation. I will go through some of the anatomy on this one. We have the muscles here, the linea semilunaris, but the important thing is the trajectory of the nerves. On the transversus abdominis here, coming into the rectus sheath here. And we want to dissect the retrorectus space. And this is seen from the medial side. You open the rectus sheath here. This is just another picture of the same thing. And now getting into this rectus space, two pictures showing about the same thing. You can do that with your finger. That's how you normally do. But the important thing is to understand the nerve here. The nerves that are here, and they go together with vessels. So they're neurovascular bundles. They are motor neurons. So if you take them all away, you will have denervated the rectus muscle. So you cannot do that. And then you put in your mesh and finalize your Rives-Stoppa. However, sometimes because the forces are in lateral direction, the hernia can become very big. So you want to try to release some of the tension here. And you can do that either. You can, of course, you can paralyze those lateral muscles with the Botox. But to do that surgically, you can release. This is a little incorrect. But what you can do is incise the fascia, not the muscle, but the fascia here of the external oblique on both sides, so that the muscle, so some of the tension will get released in order to more easy, you can close the defect here. You can also do that in posterior, and then it's important, of course, to understand this anatomy here, to take care of this nerve and to get through actually the preperitoneal space here. This is from two pictures. This is a cadaver photograph showing this is an arcuate line, just to make sure that the incision is medial to the nerves. And the same thing shown here. In order to that, you can not only release the tension, but also put in a very big mesh. That was my 10 minutes. Thank you.
Beautiful. Very nice.
Thank you. It was amazing. Now let's continue. We have a lot of classes today. I want to invite my professor Marcelo Furtado from Brazil to talk about the inguinal anatomy.
Hello, friends. You listen?
It's okay.
Okay. Thank
Yeah.
you. Just a second. Okay. Do you have my screen?
Yeah.
Okay, thank you. Thank you, Rodrigo and Conrad, for this amazing invitation. I will talk about inguinal anatomy. First of all, I'd like to apologize my English. In Brazil, we don't have time and opportunity to practice, so I try to do my best. I based my class in 2 articles. One of those is this one. We published this paper 2 years ago. It's a systematization of laparoscopic inguinal hernia repair based on a new anatomical concept. I will talk a little thing about open anatomy, but I think the more important for us is discussed the posterior anatomy that I call laparoscopy anatomy. I think it's more important for us to talk about some aspects and some landmarks that we think is important for us. This is another article from Jorge Dias from Colombia. It's very interesting because he studied the critical view of myopectineal orifice of Rousseau. And every time we study something about inguinal anatomy, no one talk about Rousseau. And I think it's Rousseau, it's the most important for us to understand the anatomy of the surgery, the anatomy of the mesh, the anatomy of the space, everything of this, you will understand what I want to talk about. Just to remember the orifice in the, this is a side edge of the abdominal radial muscles. This is the medial edge of the Rousseau. The superior edge is the transverse muscle, the arc of transverse muscle. Lateral is the iliopsoas muscles, and inferior is the pectineal ligament. It's important detail is not the inguinal ligament, but the pectineal ligament is like this one. This is the tract, iliopulpity tract, the inguinal ligament. This ligament divide the region in anterior and posterior. The anterior ones comprehends the inguinal hernias, direct and indirect. The posterior place contains the femoral place of hernias in the femoral vein. And the laparoscopic approach always cover all this space. It's one single mesh, and you'll see the anatomy of posterior place in the laparoscopic vision. This is the iliopulpity tract, as we can see in this cadaver section. This is very important in anatomy for understand the anatomy of the internal ring and the muscles of the lateral part of the abdomen and the anatomy of the hernias, of course. This is a laparoscopic vision. Here you can see the iliopulpity tract. It begins at the creases iliacus and go to the symphysis, pubis symphysis, and divide this place in anterior and posterior. Anterior is the place of the inguinal hernias. Here in the internal ring, we have the indirect hernias. In the Hasselbalch triangle, we have the direct hernias. And the femoral hernias is here in the posterior place of the inguinal region. This is the epigastric vessels. This is, for me, it's most important landmark because all my surgery, I always look where is these veins, these vessels, because they always in the middle of my dissection. My dissection is the same for medial size and lateral size, and my mesh always cover the same extension in medial and lateral. So this is an important landmark for us to understand the posterior anatomy for the hernias. So the epigastric vessels divides the lateral and medial space of the inguinal posterior region. Once again, the orifice with the space and the place of the hernias, it's always this is the epigastric vessels, and everything is in medial part of this epigastric vessels. We have the direct hernias in the Hasselbalch triangle, and the lateral we have the indirect hernias in the internal ring, and posterior of the iliopulvic tract we will have the femoral hernias in the femoral space of the femoral vein. This is important for us to understand the anterior anatomy, and now I will talk about the posterior anatomy, some important aspects based on this paper. So here we have the anatomy of the posterior laparoscopic. This is a TAP, the APP. The peritoneum is already open. So we have three landmarks, important landmarks we call inverted eye. This is the iliopulvic tract. Here we have the epigastric vessels in the anterior part of this region. And we have two structures, important structures, the vas deferens and the spermatic vessels. This is it looks like a inverted eye. And when I see this inverted eye and the iliopulvic tract, I can divide my space in 5 triangles. 2 of those is everybody knows the Dunn triangle between the vas deferens and spermatic vessels, and the pain triangle is lateral from spermatic vessels and above the iliopulvic tract. This is very important place. In this place, we can never fix my mesh with some kind of mechanical fixation. Then we have 3 more triangles. Of course, it's didactic triangles. One of these we call the triangle of indirect hernias in the internal ring, and the descriptive triangle from Hasselbalch is the direct hernias triangle. The triangle is here, the edge of the rectal, muscles rectal, the epigastric vessels, and the inguinal ligament. This is important to see where is the place of the direct hernias. And the last one is the femoral triangle above the iliopulvic tract, the inguinal ligament, and over the pubis in this place. Here we have the coronal mortis. It's always relation with this ring, the femoral ring. It's important of the recognize during our surgery to recognize this anatomy. So this is all the important landmarks in this. I think in this picture we can show the region totally dissected. In this place, you can put a large mesh, something like 18 to 15 place mesh is when it dissect like this. And important landmarks, the epigastric vessels in this place, In the middle part, we have the pubic symphysis, and the lateral part, we have the iliopsoas muscles. We always need to see these three extractories during our dissection. Independent if it is a tap procedure or tap procedure, we always need to see these elements for a complete dissection of the posterior region, and this is most important for us. Once again, I like to talk about the anatomy of the nerves. This is the Dunn triangle between the vas deferens and spermatic vessels. And lateral of this, we have the triangle of pain. In this place, we have all the nerves concerning the laparoscopic approach. So we talk about two of these, the most important. We have here this first one, the ilioepigastric nerves, ilinguinal nerves, is concerned for the open surgery. We always dissect these nerves during the Liechtenstein procedure, for example. And the posterior nerves, the genitofemoral nerve with two branches. One lateral is the femoral branch, the other one medial is the genital branch. It's these nerves, I think, is most important to see during our dissection, because it's the most lesion nerves we can do during the surgery. And here we have the ilinguinal nerves too, and the genital branch comes to the testicle like this. The femoral nerve is difficult to see during the laparoscopic surgery, and we have another one like this. Let me show you one, the cutaneous femoral lateral nerve in this place. Sometimes we can see this nerve too is more lateral, but this one is most important, the femoral branch of genitofemoral, because we always dissect this area to cover the mesh here. So important to see this anatomy. So in my 10 minutes, I try to show you the concern of what is the inverted eye and the 5 triangles, and then the anatomy of these nerves, because today we discussed so much important is the discussion of the chronic pain. Just one important detail is the place of the insertion of the femoral branch of genitofemoral nerve. Sometimes this point is 1 or 2 centimeters over the inguinal ligament, like this. So it's important to fix our mesh as high as possible to avoid these nerves. This paper is an open paper. You can see at the internet and see all of these aspects. I think it's important to read because we talk about the anatomy and we talk about the 3 areas of dissection. We always explain of our residents to dissect first of all the lateral areas, we call area 1, then the medial area over the pubis, and at least the central area in the internal ring. So this is our systematization. I think this is turned the surgery a little more easier for our students. Thank you very much. Here we have my contacts, and thank you, Rodrigo, and thank you, Comment, once again for this invitation. Thank you very much.
Thank you, Marcelo. You know, I honestly think that at least in terms of hernia repair, the critical view, the MPO, and the 10 golden rules are the most important papers that have been published within the last 5 to 10 years. In that it provides systematization, exactly like you say, or provides some guideline into a procedure so inherently variable. So congratulations to you, Marcelo.
Thank you.
And without further ado, I'm going to introduce Rama B, who probably does more webinars than I do. And he is the next speaker.
All right. Thanks so much, Conrad and Rodrigo. It's really wonderful to be talking. And since we have so little time, let's get away from the chit chat and let me start sharing my screen. Can you just tell me that you can see my slides moving, okay? Right. So my talk is on the CT scan of the normal ab wall, and I bring greetings from Kolkata, which is a city in eastern India. Probably has more people than New Zealand or Australia for that matter. Now, as a person who is a bird lover, I've been struggling with images for pretty much my whole life. Okay, so this is how a black hooded yellow oriole looks when I shoot it. And when a photographer friend of mine shoots it, this is how it looks. So this struggle with images transferred to CT scans because as a surgeon, when I started trying to understand CT scans of the hernia patients, this is how I wanted them to look. And unfortunately, this is how they would typically look. And I would be kind of uncomfortable basing my operative strategies on an interpretation like this. Think of that bird, and this is what I feel. Now, I basically want to simplify the concept that we have two complexes. One is the central complex and one is the lateral complex of the lateral abdominal wall. Okay. Now, let's have a look at this particular concept. So we have the rectus abdominis on either side. Let's just look at one side now. That's the external oblique. The internal oblique splits into two lamellae. The anterior lamella forms the anterior rectus sheath and the posterior lamella forms the posterior rectus sheath. And then, of course, we have the transversus abdominis. The point to be noted is the transversus goes past the lateral edge of the rectus muscle and inserts well into the posterior rectus sheath. Now, this most of us know, and which we do see on CT scans, but some of us may not appreciate some of the finer signs the abdominal wall is showing us on CT, which is, this is the thoracolumbar fascia, which comes from the lateral edge of the sacrospinalis actually, and then goes on to the quadratus lumborum. And from there, it splits into two layers. So this is just a representation of that on the CT. Now, what is the applied importance of this? Of course, this is again the same image. And if we look at this is the external oblique. And this is the transversus abdominis. As we know, the transversus now goes past the lateral edge and maybe occupies around 1/3 of the posterior rectus sheath, especially in the upper part of the abdomen. So when we do a transversus release for large incisional and ventral hernias, we need to divide the transversus muscle, which is inside the rectus compartment forming part of the posterior wall. Okay. So this is one of the important applied anatomical points. The other is, in this image of a lateral hernia, knowing the normal anatomy, we know this is the transversus. The one in the middle is the internal oblique. So naturally now we know that the external oblique is what forms the covering for the hernia sac. So this is an interparietal hernia, which is a typical feature of what we find in many of these lateral hernias. So knowing the normal anatomy gives you an idea about which muscle is located where in relation to that part of the abdominal wall. Now, this is a very neglected part of the CT reading by most of us. Now, this is something which I would want you to see. It starts from the thorax and we come down and it looks like the 36 chambers of Shaolin. And then at some point, you see some wavy lines coming in front of the liver, okay? Now, pay attention to how we scroll past this. Oops, I'm sorry. Yeah. So we see these images of the wavy lines. Now you see that anteriorly as well as posteriorly, you can now see the dome of the diaphragm. And if you trace it, you can actually see the entire structure of the diaphragm here. So, for example, in the ventral part, if you saw the previous part of the scrolling, yes. So if you see fat or gas in front of the anterior part of the dome, then you would know that there's a Morgagni's hernia. So this is just an example of how we should be focusing on the diaphragm as well, because many of these patients have concomitant hernias or defects in the diaphragm. Now, 6 pro tips for the surgeon, which some of us know this guy, and I think at this time of the night, I think he's the guy from whom I learned many of these things, though not formally. So the first thing I would say is, when you're looking at a representative section of the abdominal wall, compare the two sides. So if you look at the rectus on the right side, where is the rectus on the left side? So you might actually figure out that maybe this is part of it and this is the other part of it. Similarly, you look at the flank muscles and you can compare the two sides and see where are the changes. The second thing is, look at the fat both in the subcutaneous space as well as in the intraperitoneal space. And that gives you kind of an eyeballing. Even if the patient's BMI is not known to you, you kind of know that, okay, this is a patient who probably needs a weight loss at the outset. The third thing is, check whether the diastasis is significant or not and how wide the rectus muscles are. And this comes in use when we are calculating the chance of doing a component separation for a given patient. And whatever muscles you see, are they normal or are they thickened, contracted, and likely to be less compliant? So this kind of tells you whether you need Botox in a given patient or not, or you would need to do extensive release to get your defects to close. And amongst the muscles that are on display, look at the psoas major muscle, and that might tell you that this patient is too frail for a major undertaking right at this point. So this becomes an important component of frailty assessment of the AWR patient. And lastly, when you have so many structures seen on an image, for example, the right ventricle of the heart, the liver, the kidney, is the IVC, the superior mesenteric, symphysis pubis, bladder. This is the transversus, internal oblique, external oblique, and this is the left lung. Here, what one would casually say, okay, this is the sigmoid. This is actually a tumor which is partially obstructing the sigmoid. So while your abdominal wall may be a normal thing on your reading, don't forget to look at the organs that the abdominal wall houses, because they belong to the same patient. You're not paid to just look at the abdominal wall. So an expert would really look at the anatomy of the abdominal wall and also note changes inside, which may be hints of what happened to the patient. Like he may have had a bariatric surgery, or she may have had a colorectal anastomosis, and the operation that we are planning to do may be impacted by knowledge about these previous procedures. So it's kind of a point of notoriety for me to quote myself, but I think that the new normal is to know the old normal. And by that, I mean the old normal anatomy of the abdominal wall. So thank you very much, ladies and gentlemen, mostly gentlemen, I guess, since we are now one of the most notorious mammals on the planet. Thank you very much.
Yeah, thank you very much, Rama. That was awesome. To all our female counterparts, this is something that we really need to do better at. In deference to Rodrigo, we tried, but we need to try harder to include more females in the panel. But without further ado, good friend of all of ours, and honestly, if I have a radiologic issue, or if I had a question, I send it to this guy every single time. He needs no introduction. Eric Paulai. Go ahead, bud.
Hey, thank you, Conrad, very much. You guys have my screen there?
Yeah.
All right, so I'm going to spend the next 10 minutes here talking about midline hernia radiology, and I'm going to build off of the first, the first and the third talk, I guess, to talk about some of the anatomic findings we're looking for midline hernias. I have some disclosures which will really have no bearing on what we're talking about today. So, I think the thing to keep in mind is obviously as hernia surgeons, we see a wide variety and a wide number and types of hernias. And these are some things that came to my clinic billed as umbilical hernias, right? This is just an umbilical hernia, right? You can see it coming through the umbilical stalk here. This is just an umbilical hernia with a small diastasis, but obviously this guy is getting a big old open reconstruction. And this nice lady is going to get something a little more cosmetically appealing to address a smaller hernia. And so I think we as hernia surgeons are left with a variety of different ways to approach the same problem. And what we need to get good at is, as Romana said, looking at not only the normal anatomy, but beginning to understand the abnormal anatomy to do these repairs correctly. Our careers very heavily rely on cross-sectional imaging and on ultrasound imaging to help us select the right operation for the right patient. And your ability to be successful as a hernia surgeon is really not just based off of technical skills. If you bring the wrong operation to the right patient, you're going to get a bad result. And so formulating the plans for repair from my end is really, truly important. When we think about CT scans, we know that there is a very high disconcordance between what the radiologists see on the scan and what surgeons see, with hernias being the second most commonly inaccurately reported finding. And so it obviously behooves all of us to get good at looking at these films ourselves. So what I'm going to do is review some midline anterior abdominal wall hernias today. We'll spend some time talking about the interplay between the normal anatomy, the hernia anatomy, and obviously just a few things about selecting the repairs as well. Now, Romana just did a really nice job going through a lot of these slides to explain sort of the normal anatomic findings. We're going to focus our efforts here really on the linea alba specifically. So midline hernias, true midline hernias here as we see on CT and on ultrasound. But I do want to point out that the EHS classification, when we talk about medial hernias, we're talking about hernias that happen between the semilunar lines. So any hernia through the rectus muscle itself, and some hernias that obviously go through the semilunar line fall into these M versus L, lateral zones. We're talking about slightly different things. So I'm going to focus truly on midline hernias today, but realize that hernias that go through the rectus abdominis itself, for example, would fall into the EHS classification of an M zone hernia. Now, one of the things that I always remind myself as well is our radiologists do not use these M and L zones, nor do they include the nomenclature of M1, 2, 3, 4, 5, the way we think about it. But when I look at a CT scan, or really any, when I'm describing a hernia in my notes preoperatively, I use those terms. Let's also remember that when we think about hernia sizes, we want to think about the maximum width and the maximum length of all of those hernias put together. So with that, let's just briefly review some imaging studies here. So subxiphoid hernias are those that occur within 3 centimeters of the xiphoid itself. We can see a couple examples here. Things to keep in mind when you see a subxiphoid hernia. Number one is, does it truly go up like this one does and abut the xiphoid process? Or is there any normal tissue of overlap here? You can see that this hernia sac actually extends up onto the chest wall here as well. The second thing to think about is how wide are these hernias? I'm going to spend some time in a few minutes and talk about component separations and the Carbonell ratio. This is an area where when you have a pure subxiphoid hernia, I think that Carbonell ratio is really challenging to predict whether this is going to close, because as you can see, these muscles insert on the rib cage directly, and medializing tissue when it's directly inserted on a bony prominence can be very challenging. So when I see subxiphoid hernias, these are things that I think about. The other thing that I constantly remind myself about these is that these can actually contain a lot of volume. This is not a very obvious hernia because the liver is filling it here, but when this patient coughs and valsalvas, this is actually on induction, they're doing all of this, you get a very large hernia volume here. So keep that in mind. They can be deceptively large when people are laying flat. Epigastric hernias happen 3 centimeters below the xiphoid at a minimum, and 3 centimeters above the umbilicus as well. They come in a variety of shapes and sizes. Some of these are primary epigastric hernias. Some of these are incisional type epigastric hernias. Things that I look for on these, number one, these are very obvious to see because they contain, oh, you can't see my pointer, I'm sorry, I'm pointing on the wrong screen. These are very obvious to see because they have small amounts of inflammation, which makes the fat appear very obvious in comparison to the subcutaneous fat and the intra-abdominal fat. So when there's inflammation, it's very easy to see. These ones contain preperitoneal fat only. You can also follow the omental vessels up and into this one that actually contains some omental fat. So you can actually predict your ability to see a hernia sac when you go laparoscopic on these or robotic, depending on whether you see omentum going up or whether it's just preperitoneal fat. These are the ones that you're not going to see laparoscopically very easy if you're not looking for them. Umbilical hernias happen 3 centimeters above and below the umbilicus, so a 6 centimeter zone. Here's one that contains some umbilical fat. This is one of my patients actually from just yesterday who had an inguinal hernia, but when we examined him, he had a lot of fullness in the epigastric region. This was all incarcerated fat, which did not reduce, from which he had absolutely no symptoms, but which we elected to repair at the same time. I want to pause this video at the very end here to show you, pause it right here. I want you to look at what radiology is measuring as the size of the defect, which is 4.6 centimeters, and realize that they're woefully wrong, that the actual fascial gap is actually only about 2.5 centimeters on this guy. Does it make that much of a difference? No, but when they're measuring things inaccurately, you may choose the wrong operation. You may not choose to use mesh if they're underreporting the size. So again, being able to identify the edges of the fascia and measure these yourself does have some implications for the end result of the operation you offer people. Pure hypogastric or infraumbilical hernias are uncommon. Again, this is actually another of my patients just from yesterday as well, who had a pure M4 zone hernia. We can see the abdominal wall comes back together here, and we see that the M5 zone, the suprapubic zone, is actually intact. So a pure M5 zone hernia, which is actually the apex of a previous vertical midline C-section scar on her with some fat in it. Finally, pure, suprapubic zone hernias, pure M5 zone hernias are a little bit uncommon. Again, these are oftentimes low midline Phanencedal and low midline laparotomy hernias. This patient actually had a pubic bone fracture. You can see the beginning of some orthopedic hardware here and has this suprapubic zone hernia. Just like the subxiphoid hernias we talked about earlier, knowing whether you have any tissue between the hernia and the xiphoid and the pubis is helpful because you need to know exactly how far retropubic you may need to dissect. Finally, just a few things, are all the defects being accounted for? So here's a midline hernia, but an old stoma site hernia as well. This obviously all falls within the same EHS medial zone, but obviously this hernia that has a lateral component is important. I want to show you, this is the person I just showed you with this pure M5 zone hernia. And when we had our anatomy talk just a minute ago, we talked about some of these Spigelian type defects. This patient actually has a very small Spigelian defect right here, which I didn't see on the scan and I didn't find until I was doing a preperitoneal dissection. This is a trocar site hernia from a previous laparoscopic operation. As Ramana just said, if you compare the left and the right, you can see that there's fat here on the right-hand side where that fat does not exist going through layers of the abdominal wall. And sure enough, there was some preperitoneal fat stuck in here, as was mentioned earlier during our anatomy lecture, so commonly found. This is an image from Philip Moisems, As we get better at imaging the abdominal wall, I think these 3D reconstructions will help people understand what they're seeing without having to be able to interpret the images. And finally, I'm going to talk about diastasis here very briefly, just to say we have EHS classifications for diastasis. We've got several different ways to image it. Here's again one of Philip's 3D reconstructions showing the diastasis in the upper midline very easy. Here we see the rectus muscle coming from left to right, and you're going to see a very large diastasis here of the midline. This is the same patient, CT scan and ultrasound. You can see this very thin linea alba here with bowel underneath. There's the contralateral rectus on the right. Same patient here. Again, we can see this diastasis. We can see a little bit of herniation of some umbilical fat here as well. Carbon-L ratio is very helpful to predict your closure capabilities. As Ramana mentioned, if we measure the size of the rectus, if that is twice the size of the midline, you can probably get away with just a retrorectus operation. If not, you may need additional maneuvers. So a very good midline hernia maneuver to know. Calculating loss of domain, again, I think is a good midline maneuver to know, using the Tanaka ratio by comparing the volume of the hernia sac to the volume of the hernia cavity. Tanaka gave that a cutoff of 25%. The Cleveland Clinic group just presented their data at AHS earlier this year. And ultimately what they found was that while there was a proposed volume ratio of 25%, that volume ratio below 25% could predict fascial closure. But when you are above the 25%, it was not predictive of the ability to close fascia. And so there are other things like the abdominal wall stiffness, as Ramana mentioned, that are probably at play. I'll conclude by very briefly saying that denervation solely in the midline is a little bit uncommon. Obviously, we think about denervation more with a flank incision and with a big flank bulge with this denervation here. But we definitely see people who show up with isolated rectus denervation and a bulge that approaches the midline and a concern for a hernia. So again, you can compare right and left and see the denervation here. These patients may present as hernia patients, but these are not hernias, obviously. How you repair them is up to you, but keep in mind that denervation can present as a midline hernia. So I'll conclude that by saying midline hernia appearance is very commonly found in lots of different imaging studies. Understanding it is a critical skill because you're going to be able to obviously plan your repair better. Practice makes perfect. The only reason that I'm good at this is that I've been doing it a very long time. And I think that as we all get better at doing this, we will see better results, I hope, in our hernia outcomes because we pick better operations for patients. Thank you very much. I think my 10 minutes is up.
Thank you, Eric. Always learn too much with you. Hope next time you can have more than 10 minutes. Let's continue now talking about the lumbar hernias radiology with Professor Laurier. I can see your
Thank
screen.
you very much. Quite a privilege to be here. Some great talks. We're going to completely shift our focus now to the back of the patient. Let me know if if my slides are moving.
Yeah, it's okay.
The lumbar hernias, of course, occur in a very limited area, as Bengt had said nicely, between the 12th rib and the top of the iliac crest. And this is an area that's less familiar to us as general surgeons, so let's talk about some anatomy. If we begin to overlay some of the muscle groups, one of the first things that we see from the back of the patient is the broad, flat latissimus dorsi. I'm showing in yellow here. It's going to cover most of the muscles of the back, but you will see a bit of the external oblique that's attaching to the iliac crest more laterally. And notice there's a gap. There's a triangular gap between the purple external oblique at the iliac crest and the yellow latissimus. And this triangle was named after Jean-Louis Petit, who described one of the first hernias in this area. There is a second, more superior lumbar hernia, and I'm talking today in this short talk just about primary lumbar hernias, not incisional, traumatic, infectious, etc. The superior lumbar hernia, much like the nice pictures of the Spigelian that Bengt showed earlier, is not a full thickness hernia. We can't see it yet because it is underneath the latissimus dorsi from this view. We have to actually cut away a portion of latissimus or remove it to see this hernia. So let's zoom in a little bit and we'll look in at this area. We're going to focus on the tip of the 12th rib, which you see in blue here. And this forms the superior border of this triangle, or it's actually four-sided in many people, a quadrangle. Another muscle group in most people that forms one of the superior borders is a serratus group. This is actually the serratus posterior inferior. And if we look now at the medial border, we're going to see two very important muscles. In red is the quadratus lumborum that I'll really emphasize later. In green, more superficially, the erector spinae group. The lateral border is formed here by the blue internal oblique. And you'll notice that the external obliques will angle where they insert off of the ribs much more medial and be very close to this triangle as well. So again, remember that like a Spigelian, this hernia is not full thickness, okay? And that's going to be important later on when we begin to look at the CT appearance. So this is the area of the superior lumbar triangle, inferior lumbar triangle here, and you'll notice here in blue, the same internal oblique actually forms the floor of the inferior lumbar triangle. So we'll look at all of this in a second here when we begin to look at the CT cross-sectional imaging. So as Romana said, we need to understand normal anatomy first, and we're more used to the anterior anatomy. So let's look at some of the posterior anatomy. And in this cross-sectional axial scan, I want you to focus on the patient's left kidney. And just posterior to this, we're going to see the tip of the 12th rib. You see that in blue there. Scans, and we can see that fatty is a thin line that Ramon also pointed out. In this case up high, this is the attenuated portion of the transversus abdominis aponeurosis. Thin line, if you look very carefully, I don't know if you can see a pointer here, there's a thin line that we can appreciate that comes down to Gerota's fascia. This line is the lateral conal fascia. So remember that name, lateral conal fascia, because I'm going to show you later in actual hernias how this commonly herniates through the superior, what we call the Grinfeld hernia. Let's take a look now, same patient in a coronal view. Let's look for the 12th rib in blue, the quadratus lumborum in red, and again, the latissimus dorsi, you see external to the ribs, and you see, again, a nice, obvious fatty triangle. So you can see this on both sides, and this is what the superior lumbar triangle looks like in normal anatomy. We'll look at the sagittal view, same patient. Look at the top of the iliac crest. We see high above this, the 12th rib in blue, quadratus lumborum. Very external, we see the thin latissimus dorsi. And again, we see a fatty triangle right here, just under the rib. And that's what it looks like in a sagittal view. That's Grinfeld's triangle. Let's take a look at the inferior lumbar triangle closer to the iliac crest. Again, let's start off with an axial view. In this cut, you can see the patient has an incidental incisional ventral hernia in the midline. We're going to ignore that for a minute, and I want you to concentrate on the bone, the iliac crest on the patient's left. And you'll notice that where the obliques begin to come down toward the iliac crest, we see an obvious gap. And you can see this gap here, and it's on both sides. That is Petit's triangle. So let's trace out some of these muscles, and this is the way you've got to do it, as Eric shows you. You've got to look at each individual muscle and begin to trace them out. So let's look at the purple external oblique. You can see that's coming down from its origin near the rectus muscle, and you can see the yellow latissimus dorsi, and just before they hit the iliac crest on the patient's right side, they gap apart from each other. If we compare this color scheme to the anatomic illustration I showed you initially, it's the same. You see medial latissimus, and the purple external oblique is much more lateral, and there's the gap. The floor of that gap we see in blue in both images is the internal oblique, and it fuses and tapers down to the thoracolumbar fascia. We'll also notice the quadratus lumborum on the inside. The quadratus lumborum is going to form that medial border, and you don't see that in an external dissection or if you approach this open from the posterior approach, but we certainly want to keep that in mind with minimally invasive surgery from the inside. So this is normal anatomy. There's no hernia here. Now let's just take a look. Same patient, coronal view. Let's focus on the iliac crest, and we'll look at the oblique muscles. Let's look for the purple external oblique first. You can see it's right here. We see the nice blue floor of that area, again, is the internal oblique infusing into the thoracolumbar fascia. And there's a little nubbin of quadratus lumborum in red that we see attaching here. So this is what it looks like in a coronal view. Sagittal view, again, iliac crest looks narrow because we're quite medial. You can see the blue floor, internal oblique and thoracolumbar fascia, the latissimus in yellow, external to the ribs. Now we don't see the external oblique purple on the iliac crest because we're too medial in this cut, but up high where it angulates medially, we can find it covering external to the ribs. So again, take your time with normal anatomy, look at these scans on incidentally for other patients and begin to learn where you find your muscles, and you'll be able to look at them when you see pathology, you'll understand them better. So let's switch to pathology now. Let's talk about actual hernias. And let's again follow our friend, the 12th rib. So we'll begin where it's close to the vertebra here. We will trace this as we scroll inferiorly on our CT scan of the axial view, and we'll look at the tip of that rib, and we see an obvious abnormality. The purple is just that serratus posterior inferior inserting on the rib there. And you'll notice there's something very obvious going on in the lumbar region on the left side. Let's look at the normal side, as several people had pointed out, Ramona, Eric, before. Let's look at the normal side and look at the yellow latissimus. You see how nice and flat that is? It's obviously bowed out on the pathologic side. The hernia contents are pushing a big convexity, and I call this the latissimus balloon sign. And this is very pathognomonic, very specific for Grinfeld's hernia. So look for that in your patients. As we scroll down, we can see the kidney is often seen in the same axial cut as the actual Grinfeld's or superior lumbar hernia. Let's look at some of the muscles here. This is psoas muscle, just in this case, medial to the kidney at this level. Quadratus lumborum in red, and then erector spinae in green. So these two muscles are going to be very important, again, forming the medial border of this hernia defect. That's the lateral conal fascia. You see that connecting the descending colon and the kidney? It's herniating out into the defect, and we can actually see that on our CAT scan. And if you approach this from the inside minimally invasively, you will see what looks like a pseudosac. It looks like a peritoneal sac. It's a defined thick structure, but there's no peritoneum, of course, in this extraperitoneal space. So we can predict what we're going to find when we look in laparoscopically or robotically. Let's go ahead and look at the quadratus lumborum, and notice as we scroll down toward the iliac crest, it begins to project way out laterally. In fact, as we follow this all the way down, we can see the tip of the iliac crest, that little white bone just beginning. Now look how far the red quadratus extends laterally compared to the green erector spinae. Very different view than we saw up higher. So same patient up higher by Grinfeld's hernia, you can see that the erector spinae and the quadratus lumborum is much more medial. Now we'll go back to this image. We're going to scroll down to finish off seeing the iliac crest. There it is. And let's take a peek at the coronal view in this patient. And so once again, we'll look at the 12th rib. It's actually right there in front of us. We'll color it in blue and follow it out to its tip. And there you see, just inferior to this is the hernia. And you can see quadratus lumborum. We can see the same latissimus balloon sign, even in the coronal views. There was a little herniation of that pseudosac, the lateral conal fascia. Incidentally, on the other side, we see Petit's triangle. There's no hernia there at the top of the iliac crest. Let's look at another series, and I'd like to thank Nico Quezada from Chile for this scan. And we're going to be looking for a true Petit's hernia, but first let's look at the normal triangle up higher, the superior lumbar triangle. So again, look at this time on below the liver and the kidney, you'll see the tip of the 12th rib, and we'll begin to scroll down. At the same level, we see the insertion of the serratus posterior inferior. You can see that in magenta there attaching to the rib. That's actually the 11th rib it's attaching. But as we scroll down to the top of that superior triangle, we saw our roof, which is latissimus dorsi. More laterally, we see the oblique, and the latissimus overlaps that. We see the floor in blue, the internal oblique. And then the muscles we're becoming used to now, the quadratus lumborum and serratus and erector spinae. There's our fatty triangle, okay? And you can see that thin floor. Again, corresponds very nicely with the color scheme that we showed you earlier. This is available on YouTube on my site if you'd like to spend more time with this. So now let's scroll down, and we're going to watch the lineup of this quadratus lumborum as we go lower. It begins to extend laterally. But let's focus on the external oblique in purple and latissimus as they begin to gap from each other just before they contact the iliac crest in Petit's triangle. You'll see we have some herniated material now through that triangle, so it is in fact a true Petit's hernia right here. And we see the quadratus lumborum on the inside as that medial margin. Look how far out that quadratus lumborum is sticking out well beyond the erector spinae. See how far it doesn't line up anymore like it did up high in the superior lumbar triangle near the 12th rib. You can see there's bowel content herniating out. The hernia contents are contacting the iliac crest. So again, another indication this is a Petit's hernia. And let's look at finally at the coronal view here. You can see quadratus lumborum. External oblique hasn't attached yet. It's where it's gapping still. As we move more anteriorly, that external oblique comes down and attaches to the iliac crest, getting toward the anterior superior iliac spine. So true Petit's hernia there. So I think what's important here is to point out that I really believe the quadratus lumborum is the key landmark for us to understand when interpreting lumbar hernias, whether that's operatively or here on a CAT scan in preoperative planning. I've already pointed out how up high, you can tell you're up high because the quadratus lumborum lines up with the lateral border of the erector spinae, but inferiorly, it is much more lateral, as you can see here. So by looking at a single CT slice, you can tell if you're near the area of the superior or inferior triangle, even without having the whole series. You can already begin to guess where you are. So in summary, I'll wrap this up. Superior lumbar triangles are going to occur inferior to the 12th rib. We often see the kidney on the same axial cut near the hernia. The two key signs are going to be this quadratus lumborum lining up with the green erector spinae and the latissimus balloon sign. So look for both of those to confirm that it's a Grinfeld-Leschaft hernia. For inferior lumbar hernias, again, you have contact with the hernia contents with the iliac crest. The gap is happening between the purple external oblique and the latissimus dorsi. And of course, that quadratus lumborum is now far lateral to the erector spinae border. So thank you very much for your attention. Obviously, these are all nicely colored for us. Again, as I mentioned, this is available on my YouTube site if you want to spend more time. Do that, look at the colors so you understand these things, and then begin to look at these things, obviously, without color in your own patients, so you can trace out each layer carefully, spend a lot of time with it, and you'll soon become much more facile at identifying these things ahead of time. Thanks again for your attention.
Professor Laurier, I had the idea to do this event today, talking about radiology after you post this video at IHC. So I think it's the best lecture I have ever seen. Thank you.
Well, I credit Eric Pauli for being a tremendous inspiration to all of us.
You have to teach next time how to do a movie. It's perfect. Thank you. Professor Tachi and Radiology of Inguinal Hernias.
Rodrigo, thanks for the invitation. It's tough to talk after Professor Lourier, but I'll try my best. I'll discuss only inguinal hernias radiology. I won't discuss masses or other things. So I'll focus on the diagnosis of inguinal hernias by radiology. These are my conflicts of interest. They won't have any change in my presentation today. So I used some resources that I will take some time for you guys to take a picture of the screen or do a print screen. So if you want to have some more information about, not only about inguinal radiology, but abdominal wall radiology as a subject, these 3 books, they have very nice chapters. This one is written by a very nice friend, Ben Pelouse. This book has a very nice piece of description of the inguinal radiology. And this one, which was published just this year, have a lot of what we have discussed today. So if you guys want to go, this will be a must-have. There's scarce literature about which is the best examination for inguinal region. And these are some of the meta-analyses that I used to do this paper. So after reading a lot of things, and I read a lot of papers, but as I told you, scarce papers, they are not randomized controlled trials. They are the evidence, the bigger evidence I found was 2 or 2A. And I can start discussing the subject by pointing if it's really necessary to use radiology for inguinals. This is a very interesting paper. It was just published like by the group from Greenberg, showing that 47% of the patients that were operated for inguinals, they have unnecessary imaging examination 6 months prior to surgery. And that's very interesting. 32% of these 47 were CT scans with the related radiation that is applied in this situation. So we have to think, it's really necessary to use radiology for inguinals? Probably no. This is a study from Schwinn-Tofai. She showed that and it's the only study that points that MRI probably will be the last resource for inguinals, especially when we have a patient that has a clinical scenario, but when clinical symptoms, but when you do the examination and you go through all the steps, you can't find a hernia. So what is my point after reading everything? Probably what we should use as a routine is the ultrasound. Probably it's important as the first examination with and without Valsalva. It has a good sensitivity and specificity with a predictive positive value of 92%, and probably should be the first line assessment. The CT, this sensitivity range, and we use a lot of CTs to see inguinals. Probably it's not as better as MRI, but we're going to see in the next step that MRI is tough to read and it's not usual for the surgeon. Probably CT is helpful when searching for other abdominal conditions and for uncommon hernias like obturator or femoral. When we discuss about MRI, of course, it's very it has a high sensitivity and specificity and can be useful for acute inguinal hernias, especially in this scenario where you can find it in the physical examination or in the CT scan or in the ultrasound, sorry. But surgeons are not used to read MRI. And we should remember that it's a very cost and time consuming. Just to put some historical notes, herniography is still done in some places, even with CT scans. So what's my idea here? I will discuss with you in a very few slides the radiologic appearance on the computed tomography from the inguinal region, and then we're going to go straight to the ultrasound, which is much more common for the surgeons. So it's all about anatomy. And then Marcelo did a very nice job for me showing all the triangles and everything that we should have. But the most important part to understand the CT anatomy is the vascular anatomy. Understand where are the inferior epigastric vessels and where are the external iliac vessels or the femoral. You can call it whatever you want. So this is what the radiologists, they call the lateral crescent sign. And let me point for you guys. Otherwise, if it's not written down here, I will always show only right inguinal hernias, just for a purpose of padronization. So here, what you can see here, you identify the vessels, you identify the cord and the contents of the inguinal canal, and you can see this, what they call the crescent sign. So this is fat that makes like a moon in the crescent part of the cycle of the moon. And they call that this is very typical of the occult inguinal indirect hernias. So here we will look always for the same things. This is the femoral vessels. These are the inferior epigastric vessels. And you can see a bulge protruding on the lateral aspect of the inguinal region. This is an indirect inguinal hernia. I will just take out the arrows for you guys to understand. So we're gonna always use the femoral artery and vein and the inferior epigastric vein to have our landmarks to understand if this is a direct or indirect inguinal hernia. This is a picture of a direct inguinal hernia. You can see the femoral or the external iliac vein. You can see the artery, you can see the inferior epigastric vessels, and you can see a bulge protruding medial to the artery. That's a direct inguinal hernia. And the femoral hernia, this is a left femoral. That's probably the only image I will show about left. So here you can see a fat that is protruding just medial to the vessel. And this is a femoral hernia. This fat protrudes below the inguinal canal. The ultrasound examination will focus on the inguinal region, and we can have a lot of ways to look for hernias in this situation. But again, the most important part of the understanding of this anatomy is to understand where are the external iliac vessels and the inferior epigastric vessels. If we have a defect that is medial, we're going to have a direct hernia. If we have a defect that is lateral to the inferior epigastric artery, we're going to have an indirect defect. So here, we're always going to search for the inferior epigastric artery. And how are we going to see that? We're going to find high in the abdomen, and we're going to come down to the hypogastric until we can see it arising from the external iliac artery. When we do this, we can understand if we're dealing with an indirect, direct, or a femoral hernia. Let's see how they appear in the examination. You can find the inferior epigastric artery. You're going to see contents protruding through the inguinal ring if you do maneuvers like Valsalva, for example. So here there are two ways that this can protrude, as a big protrusion or as a small protrusion that goes just to the inguinal canal. So here you're going to see a movie. You're going to see here the inferior epigastric, and you're going to see some fat right now when the patient does a Valsalva. You see that here is the inferior epigastric artery, and you can see the same image I showed you. This is fat protruding through the internal inguinal ring, which is here in the inguinal canal. And here you can see the same image, the patient relaxing from Valsalva, and you're going to see the fat coming outside again. So here you're going to see the same fat coming back when the patient stops to doing Valsalva maneuver. Again, this is a right inguinal indirect hernia. And here you can see the artery, the vein. This is the iliopubic tract. Sorry, here is written ischiopubic tract. And here you're going to see what happened when patient does Valsalva. This is a normal ultrasound anatomy. This is pre-Valsalva. You can see the inferior epigastric artery, which is our landmark. And here you can see the hernia protruding on the top of everything and lateral to the inferior epigastric vessels. When we deal with direct hernias, we're gonna see that, again, this is an indirect, which is lateral to the inferior epigastric artery. This is a direct, which is medial to the inferior epigastric artery. And here you can see the inferior, and you can see the protrusion of the fat, which is going through the to the triangle half buck. The femoral is easily to see. You're going to see a compression of the vein when you have, especially when you have Doppler ultrasound, as I'm going to show you in a while. Just 1 second. Sorry, I have a video, a very nice video of this. So I just 1 second, and I'm almost finishing. So here we can see the artery and the vein, and we can see that when the patient does Valsalva maneuver, you're going to see compression of the vein right now by this bulge here, and we have the diagnosis of a femoral hernia. So my take-home message: in most regular cases, radiology is not necessary. We should start with ultrasound if we have doubt, but this is an operator-dependent examination. Vascular anatomy is the key for correct identification. CT would be the next step when clinical scenario is suggested, but US is negative. And MRI should be reserved for high level of suspicion when other examinations are inconclusive. And some centers where you have a dedicated radiologic team, you can think about radiology. Thank you, Rodrigo, and sorry for the 1 minute more that I used in my presentation. And I hope to have some questions after we finish everything.
Tachi, that was amazing. You know, I struggle with inguinal anatomy, and the way you broke that down was really good. A nice systematic way, especially with ultrasounds, because you know you can theoretically ultrasound right in your office. I really need to employ that more. So for the next lecture, it's going to be Sal Dosimo. He's in Long Island at Stony Brook. We're trying to get him over here to Phoenix. Hopefully at some point he can go and do that. But he's going to be talking about post-op complications by CT scan.
All right, guys. Rodrigo, Conrad, thanks a lot for the image. You guys see my screen okay? You guys see my screen all right? Yeah? Okay.
Yeah, sorry. It's okay.
Sorry, disclosure, just a consultant for Boston Scientific, but not relevant to this lecture at all. So complications. So, you know, this photo, Eric Pauli has spoken about before, and, you know, it's sitting in his office. So this is just to prove that I've actually paid attention to him during those years of fellowship. But, you know, this is a true statement, obviously, in terms of an expert as an individual who, based upon his own painful experiences, to really slowly start to understand what is going on in their field. And they've made all the mistakes in a very narrow area. And this, you know, you don't really understand this concept until, you know, when you're a resident, even when you're a fellow. But when you're on your own and you have your own patient that is having an issue and you send them off and you get a CAT scan, and now you have all these images and all these findings, you really need to understand and start to really get an idea of what you need to do. And how, you know, you have to make a decision. Are you going to go back to the operating room? Are you going to watch the complication? Are you going to follow it? And I think over time, what you start to realize is that you really need to leverage and really take advantage of all the tools that you had. So for individuals who are doing complex wall reconstruction, obviously leveraging the information that a CAT scan gives to you, especially after these complex wall reconstructions, is so important. So some objectives that we're going to kind of look at today is going to be looking at the basic tools for really reading CAT scans. So what other information can we use and leverage to really guide us in terms of what we're going to make a decision in terms of our patients? Looking at ventral hernia recurrence, some images. Obviously, you know, we don't have we can look at this all day long, but I think we can try to give the audience here a little bit better understanding in terms of what to do when you see these recurrences, and also CT scans of the inguinal hernia. If we have a few minutes left, we'll just look at that briefly. But for the most part, you know, surgeons and CAT scans, and Dr. Pauli briefly touched on this earlier as well, but when we're looking at CAT scans, we really want to know where the hernia is, meaning that exactly where is it located, and we want to really you want to scan the CT scan, because a lot of times, especially when you have recurrences, or if you have an incisional hernia, there's going to be other areas where there's going to be other hernias, and you want to take that into account when you're doing your surgical repair. So you want to know where the hernia is, what the size of the hernia is, and obviously the type, you know, is it incisional, is it primary? And a lot of times when you look at reads that you get from the radiologist, you know, this information is not there, it's missing. And this is all really important information, and it's not really reported by the radiologist. And again, they're obviously, you know, they're looking at other stuff. A lot of times they're going to say, hey, there's a hernia here, but they're not going to describe it in a way that you're going to be able to use it to perform your repair. So sometimes an example of this too is like sometimes you'll get a CAT scan where there's a midline hernia, but then they also have a small Spigelian. So you want to make sure that you have significant mesh overlap. So just a Rives-Stoppa may not be sufficient. So that's one example. And again, one of the important things is that you really want to, we as, you know, societies, and we as individuals who are really kind of pushing hernia repair, we want to start to standardize our language and how we describe these hernias. So again, I mean, I'm going to present this as well here. And you know, when you start doing your op reports and you describe these and you see patients in your office, start to use these guidelines in terms of how to classify these hernias and have this language and this, you know, these ways to describe hernias propagate throughout, you know, all the surgeons worldwide. And then over time, hopefully this will become our own language that all of us can understand and better describe this. And hopefully this will also be adopted by radiologists as well. Okay. So why is this important, understanding how to use these CT scans in hernias? Is because a lot of times you can use this for your preoperative planning. And even, again, even if you're having a complication, which most of the time a lot of people will have are recurrences, you know, you're going to be able to use the information to really figure out what type of surgical repair you're going to move forward with. So if you look at defect widths, for example, or even defect area, you know, you can measure this on the CAT scan yourself and get a really definitive measurement. It's going to decide in terms of what type of procedure you're going to make. So the data says that if you have a defect greater than 8.3 centimeters in width or area greater than 164 centimeters, you may want to think about maybe doing a component separation. So you want to keep that in the back of your mind. You know, just saying, oh, well, this looks small. You know, I'm gonna book this for 2 hours. It may become a 4-hour procedure. CT's measurements of the abdominal wall. So also looking into the future now in terms of what work is being done is really looking at, you know, things such as visceral adiposity, subcutaneous tissue, things like that, that may actually alter the outcomes for some of the patients. So if you look at the picture here of this CAT scan, this is looking at some visceral adiposity. So a lot of work, and this is really in the infancy as well. So just, you know, down the line, just keep this in the back of your mind that this may be coming down the pipeline, and we're going to see that this is actually going to be really helpful in determining outcomes for our patients, or better, improving outcomes, I should say. So significant, again, and why do we want to stress this? Why do surgeons really want to learn how to really read CAT scans and any imaging for that matter, not just CAT scans, even ultrasounds and MRI? But because if you look at the reads between just surgeons and radiologists alone, again, there's a 70% rate of discordance between these individuals, okay? And these are both experts in their field. And this is, you know, what people think is a simple pathology, but it's obviously not. It's fairly complicated. So you really want to be able to be pretty good at reading these CAT scans as well. So this is important. This is an important stat to remember and to keep in the back of your mind, okay? So now getting into the specifics of it, I think one of the important things, certainly when dealing with complication, is you want to know about the mesh that is being seen on the CAT scan, or more importantly, the mesh that's not being seen on the CAT scan. And it's tough to see these sometimes. It really is. And what's the most important thing about the mesh itself is, in terms of whether or not you're going to be able to see this on an imaging, is what the material of the mesh is, what the thickness is, and then also what's the mesh coating, okay? Mesh that's typically seen in radio-opaque on CAT scans are those thick meshes, dense meshes, coated meshes. They're going to be, they're going to have significant radio opacity. Radiolucent mesh are, again, ones that you're not going to be able to see. So what do you do with them? You may get lucky where on a CAT scan, you may have a nice, you know, plane of fat above and below the mesh where you can actually see it. Or if there may be some significant rippling or scalloping in the mesh, then you'll get lucky to be able to see it. But for the most part, you really want to also get the operative report. If this isn't your patient, or if it's a referral, they had a history of a surgical repair in the past, get the operative note, because, you know, a lot of times you're not gonna be able to see the mesh clearly on the CAT scan, but if you have some guidance or some idea of what was done before, you may be able to actually be able to tease out the CAT scan, the mesh on your reading. Biologic mesh on a CAT scan, especially if you're 6 to month, you know, a couple years out, highly unlikely that you're going to be able to view it for the most part. what makes mesh visible on the CAT scan? Again, it has fat surrounding it. There may be wrinkles or scalping. If there's tacks, the tacks a lot of times you're gonna be able to really almost see the circumference of the mesh for the most part. So you want to use these different fine points to really try to localize the mesh on your CT scan. For the most part, mesh that's in contact with the muscle is simply not going to be seen. So I'm not going to go over this in the sake of time. I'm not going to go over this in detail. But again, this is available and it's out there. Take a screenshot of this, or look at the references, or they'll all be available. But this will give you a good idea in terms of what meshes are visible to poorly visible. And then for the most part, again, it's if you look at PTFE, you're looking at more like dense mesh, things like that. Those are going to show up very easily on the CAT scan. They're going to be bright white, can't miss it. We'll see some pictures here in a second. So mesh on a CT scan, and again, these are just a couple pictures here, just to kind of get an idea. So this mesh here on the left, again, there's some fat above and below, so it's pretty obvious. This is like an IPOM placed mesh for the most part. And what's important is you can see the scalping here. So these wrinkles are what's important. They're abnormalities in the mesh themselves. Your peritoneum is not wrinkled. So when you see these abnormalities, you're gonna have a good idea that there is a piece of mesh there. Here's another mesh very similar, but what you can use here, again, as we mentioned earlier, is that there's some tacks. So the tacks are really going to give you an idea that, hey, there is a piece of mesh here. And then you can clearly see this too, that this is ripped away from the left rectus muscle. Comparable to the right, you can see they had fantastic overlap, but there clearly was not enough purchase on the hernia defect on the left rectus, and this thing just snapped. So you can see the clips here are just kind of free floating in space. So again, these are little things, the scalping, the mesh, the clip, the tacks that have been used. You can use them to actually identify and localize. And then once you find these tacks, you can work your way back and say, okay, now I see the mesh. I know that this mesh is going all the way lateral, right? All the way to the end of the rectus here. So if you're going back in to take this mesh down laparoscopically, or if you're going to do it open, you know how far out you're going to damage the peritoneum trying to get this mesh off, okay? Then here's an online mesh as well. So I put that on there to give you an idea of what it looks like. You can see it's lying right above the rectus abdominis muscle. What's important here too is, why can we see this pretty clearly is, again, what we mentioned before is that you actually have a plane of fat here that's lying above the rectus abdominis and the plane of fat below. So this lights up pretty well. So ideally, if you're going to do an online mesh, I mean, if we had to criticize this picture here, you wanted to take down much more of this fat plane, and this thing should have been sitting pretty flush to the rectus abdominis. I shouldn't be able to see it this clearly, okay? So these are things to look for. So you can use the advantage, you can take advantage of some of the other, what the surgeon did previously. And then here's another situation where this mesh is really completely detached from, and it's within the intraperitoneal cavity. But now what's important here is that obviously there is a mesh here, you can see it, right? But what's important is, say we're going to go back and repair this, we're going to do an open repair. So you can see there's a bunch of fluid here. What we want to look at here is that this mesh is also completely detached. It's actually sitting within the intraperitoneal cavity. And what's important here is that when you're going to go in there and tackle these patients, is that you want to be aware that I don't really know exactly, right? I know that there's a mesh here, but I don't know what the quality of the barrier is. But I can see that this mesh is dangling down within the intraperitoneal cavity, and there's a loop of bowel here, and there's a loop of bowel here on both sides. If I was lucky enough, there's a barrier, the barrier is likely going to be on the right side. If we're looking, orientation is going to be on this side of the mesh here. So hopefully this bowel is going to kind of come off pretty easily. But I know on this side, there's not going to be a barrier. So this mesh is going to be probably fused over time with the bowel. So we have to be careful of that. So when you go in, so this gives you an idea in terms of when if you go down the midline and you get onto this mesh and you kind of work your way out laterally and into intraperitoneal cavity, when we get to this part of the abdominal wall, this part of surgery, we need to be really careful here and how we take down this mesh. So again, this is using your images to really plan your surgical approach. When I'm going down to on the right side here, this thing is going to come right off. Hopefully the barrier is still intact and this won't be too bad. But when I go over here, I know I have to slow to put the brakes on a little bit and be careful because I probably have some adhered bowel there. So now, what other complications ahead? So how can we start to leverage the CT scan to really make decisions in terms of how do we treat our patients? And again, one of the more common complications that we are going to get is the patient's going to come in, they're going to say, I feel something here, there's like a little bulge. You're going to get some imaging or a CAT scan, and you're going to see that there is going to be some fluid collection there. So you really want to you want to understand what that fluid is, right? Because if it's a hematoma versus a seroma versus an abscess, these are very different things. So Hounsfield units are really useful, and they're available to really all of us for the most part to get when you open up your CT scan, you should have some options there where you can highlight an area and you get the Hounsfield unit. So we have to really start to use this a little bit more. And again, it goes from air being 1,000 up to bone, which is the most significant density. The Hounsfield units, again, is just really ratios. So bone is the densest at 1,000. So now we look at fat. Fat is minus 150 to 100. Blood, so if we see hematoma is about 40 to 70. Water is about 0. But what's important is seromas. Why? Because we see seromas a lot. And you always get the question is, okay, should I drain this thing? Should I not? What is it? Is it infected? But seromas for the most part is 0 to 20 Hounsfield units. So you can really use this to guide how you're going to deal with this complication. So if you see the fluid collection there, check the Hounsfield units. If it's low and clinically the patient's doing fine, for the most part, you probably can watch it and it's going to resolve with time, okay? And then again, the other things to look at, there's no significant rim enhancement as well with a seroma, whereas in an abscess, which we'll show you here, there's a significant rim enhancement. And again, also you want to look at the quality of the seroma. We can't just say, well, you know, a Hounsfield unit of 5, it's a seroma, I'm going to leave it alone. You really need to understand what is the seroma doing in relation to especially mesh. So if there's a seroma below and above the mesh, that can be pretty different, right? So if you have a seroma that is within the subcutaneous tissue, in which it's really not adjacent or just adjacent to the mesh, you could probably just watch it. But if the seroma is above and below or below the mesh and the mesh is just free floating in this collection of fluid, there's not much going on there. You're probably going to eventually have to go in and deal with it. Hematomas, again, are more dense, right? So blood is going to be more dense than water, so you have a higher Hounsfield units. Things to look out for is, you know, obviously, you know, is there a blush? Do you see some contrast within the lumen or within the opening of the hematoma itself? If you do, you're probably surgically going to have to go in and look at and deal with that, or even send them to IR. But again, they're going to be more dense than the seroma. So if you get a Hounsfield unit closer to 70s and 80s, I would be very mindful that on the CAT scan, that's likely going to be a hematoma. Abscess collections, these are a little bit tougher actually to really figure out what's going on, because the Hounsfield units in an abscess are lower. They're going to be lower than they're going to be somewhere almost very similar to a seroma, but they're going to be much lower than a hematoma. So we can easily rule out a hematoma when we see this. But you want to see that there's a significant dense peripheral enhancement on the imaging for an abscess. And again, you want to look for small little locules. You know, what you can do on the CAT scan is just put the CAT scan to the window imaging, right? Same thing, or the lung view. Scroll through the collection. If you start to see little black areas, that's going to be air. It's probably going to be an abscess and probably should be drained. Okay. Now, evaluating the musculature. This is just a standard picture. Obviously, all the musculature here is lit up because why? Because anytime you're dealing with a complication or having some imaging, you understand what the muscles are and what you're dealing with. Okay, so you want to know the normal, right? To understand abnormal, you need to know normal. Now, the other thing to look and be understanding and mindful of is how can we use the CAT scan to better plan what we're going to do in the OR. So obviously, you want to look at the fatty distribution, which we kind of mentioned before. You want to look at the rectus width as well, right? The rectus width is very important. You want to know because on your screen on the left side here, you're going to see that the width is really nice. So you have a long, large rectus abdominis muscle. You could probably do a retrorectus repair here. On the left side, you know, you have a very small one. You may have to think about maybe possibly doing component separation. Look at the lateral abdominal musculature. Here you can see they're kind of thin. They're a little thinned out here, but you have a large amount of area to work with. Whereas on the other side, on this side here, on the right side, you can clearly see that they are pretty contracted, very small. So you're probably going to need a little bit more of a component separation. And then also sarcopenia, as a bunch of us actually touched upon this, is sarcopenia is a big problem for these patients, right? You want to know, are they going to be able to tolerate going back in and fixing a major recurrence or major complication? So if you look at psoas here at this complex, you can see that there is nice, solid, dense muscle, healthy muscle. Probably this patient would tolerate as well. Whereas here you can see a lot of marbling within the muscle. This means that there is a lot of sarcopenia going on there, which means the patient may not be as healthy or a good candidate for significant repair. Okay, so we can use these this information from a CAT scan to determine our possible outcomes for our patients. Carbonell was already spoken about, but I think it's an important concept to know, especially if you're going in for a recurrence. It's really the defect size or the retrorectus space. If it's double or greater than 2, a ratio greater than 2, you're probably going to have to do a component separation of some sort. Now, again, what to look for additionally on the CAT scan, okay, is you want to see, do the imaging match up to what you're seeing in the op report and what you're seeing also in your physical examination? Where are all the defects? Again, you really take your time to scan them because you'll start to pick up smaller little defects. Again, a lot of times patients who might have had a significant midline laparotomy, they're going to come in, they're going to have a huge midline hernia, but a lot of times they may have gotten a stoma that's been reversed, and you know, the radiologist may just say, well, you got one large ventral hernia, whereas in reality, you also have the stoma, which could be a Spigelian, which means that you're going to need a much larger overlap. So that's a much bigger procedure than just a straightforward midline. So that's why you want to look where all the defects are. And again, where's the mesh, which we kind of talked about, and also denervation of muscles. You can see here, it's just quite clearly the rectus muscle here has basically been obliterated. It's gone. It's completely atrophied. Okay, so this is going to come into play in terms of what what type of repair you're going to do. Because on this situation here, where your rectus muscle on the left is almost completely gone, you're probably going to use more of a heavyweight mesh versus like a lightweight mesh. All right. So the imaging alone here, when I see this, is going to determine what I'm going to do before I even get into the operating room. So in my mind, I'm going to say, okay, listen, I got to make sure I have a large heavyweight mesh available to go when I fix this hernia. Now, looking at some of the hernia recurrences in our last few minutes here, what's important is you also want to, you can use the CAT scans to your advantage in terms of knowing what anatomically is going on in the abdomen. So when you look at the CAT scan, know where your levels are, right? So if you know you're below the umbilicus, that's gonna alter in terms of what structures you have there from an anatomical or muscular plane, right? So then also is you're going to get a better understanding in terms of what you're going to see when you get back into the abdomen. So in this specific individual, you can see that they had significant herniation actually between the rectus abdominis muscle and also the posterior rectus sheath. This is an individual who had a history of a TAR. And when you can see the rectus muscle here actually, as we were taught, as Dr. Paul was mentioning earlier, it almost looks like one motor complex. However, there was a huge defect that had occurred here, and now they have a major herniation between the rectus abdominis muscle and then also that posterior sheath as well. And you can see how far laterally this is extending to, which means that this muscle is probably going to become significantly denervated as well. Okay, so you know that when you're getting in there, what you're going to be dealing with is probably some terrible rectus abdominis muscle. But all our planes have also, been pretty obliterated. But you're going to have an idea that you're going to need a significant component separation to repair this. There's no way about it. But you can also get an idea in terms of what was done surgically before you even get there, even without the op report. All right. So now this this CAT scan here, you can see at we're at the level about the umbilicus. There's a hernia sac that's between the rectus abdominis muscle and also that posterior rectus sheath and mesh as well. And you can see that all of this is sitting really right below the rectus abdominis muscle as well here. So this was this hernia itself actually herniated straight through that posterior rectus sheath, completely broke down, and all this is sitting right below the rectus abdominis muscle and even starting to extend here laterally too. So this is again another one. This is again in another patient here where the posterior rectus sheath is completely broken down too. What's important here is you can actually see that some of the bowel is starting to creep up in here. You can see that there's a big fluid plane as well. Okay, and what's important is that this mesh, you can start to see some of the mesh here that's sitting in that retrorectus space, but it's failed here, and you actually have a loop of bowel. And what gives it away is obviously that little blip of air. So I know that this is something that obviously cannot be observed. And again, it's kind of subtle, but that blip of air actually gives it away, and you can kind of see the loop of bowel here. So this is a patient that definitely you need to go back and take care of this, whether it's going to be open or laparoscopic in nature, to go and get this bowel down. But this is not something that you can sit there and just kind of observe. So this is one of the more painful and scary complications of a TAR. You can see the linea seminalaris has been completely disrupted. You can see the rectus abdominis muscle here. And again, you can see that if done correctly, obviously the rectus abdominis muscle should be that one entire motor complex. You can kind of see that there is really no separation to the rectus abdominis, but when you come here laterally, you can see what's left of the external oblique, internal oblique, and even some of the transversus actually. But you can see that the herniation has occurred straight through the linea seminalaris and is herniating all the way lateral above the lateral abdominal wall. So, so right away you can kind of understand in terms of what is going on in this picture. without even knowing what was done in the op report. Just by looking at the musculature, you can understand that you're dealing with a significant failure when the TAR was performed. So difficult problem to fix. And obviously, using the CAT scan here to really have a good plan of what you're going to do when you go in there is important. So this here is another patient who had another TAR. Again, it was complicated by the linea seminaris, and also you can see that the posterior sheet is actually starting to break down too. But what's interesting to see is that the hernia contents is herniating above a still mostly intact posterior rectus sheath. Because if you look at this yellow line here, this was all the posterior rectus sheath, and this is herniated actually above it. We can see all the abdominal contents are sitting on this posterior rectus sheath as well. All right, so that's kind of, it gives you an idea again by looking at the CAT scan in terms of what procedure was done, and then also the complication that the patient is having. So kind of putting all this together, how does this affect what you're going to do in terms of, one, understanding what complication the patient had, and then also how to deal with it. So looking at this, I know that this patient probably had a PTFE mesh because it's lighting up pretty brightly here. I also know that there is a fluid collection here. You can see above here. And again, in this picture here too. So what are we going to do with this? Again, now using this, I know that I have to also examine the patient, right? So the patient came in with an actively draining sinus, and she actually had a drain placed to drain this, but it keeps accumulating. So looking at this finding in terms of the mesh here, one, I know that this mesh is obviously infected because this looks even more so. You have some area here that may be evidence of seroma, but this also looks a little bit thicker. The hernia repair was done a couple of years ago, so it's likely a chronic infected mesh. You want to start to see whether or not there may even be a fistula, and you have an idea that there may be a fistula there too, because this mesh is in direct contact with some of the bowel and it may be feeding bacteria to this mesh, and you're getting this chronic infection. But you can also see that this mesh is completely detached from the musculature, so she also has a recurrence of her hernia too. So you can get a lot of information actually just from the CT scan. So I know that by looking at the CT scan and understanding what we're seeing is that this patient eventually will need to go back to the OR. She wants to have this repaired. This mesh is going to come out, and we may even have some issues here in terms of a fistula. But for the most part, she's had like before she came to see me, she had some drains placed, and she's been on chronic antibiotics. But I know that looking at that there's a foreign body in here with continued thickened fluid so adjacent to the mesh that this is probably a longer standing problem that's not going to be fixed with antibiotics. So again, the proficient, I'm going to finish up here. Sorry guys, I'm going a little bit over, but looking at just understanding, reading the CAT scan is also important, is because this is a patient who had a laparoscopic left inguinal hernia repair, and she continued to have a little bump there, and she came in, she was concerned that she had a significant recurrence. She had a CAT scan done, and on the read of the CAT scan, it said that she had a stable or a stable recurrence, whatever, recurrent hernia on the left side as compared to other CTs. But when I look at the CT, it looked like actually there was just some retained piece of fat in there, but there was actually no fascial defect. Actually, the repair was completely intact. There was no true hernia. So when I called the radiologist up, I said, hey, this is not a recurrent hernia. It's a retained piece of fat. And he agreed. He looked at it from multiple different views, and he actually had done them the report. And the report now states that there's no hernia recurrence there, but it obviously was a retained piece of fat. But that's a very different approach, right? So if you want to really take out that residual piece of fat or lipoma, you can just cut down and take it out rather than doing a full-blown hernia repair. So again, that stems from the fact of not just taking the radiology reading at heart, but understanding that when you look at the CAT scan yourself, you're going to pick up things that the radiologist may not know. For the sake of time, I'm just going to go over very briefly here, but CT scans of inguinal hernias, again, for non-occult inguinal hernias, they have good sensitivity, but for the most part, I would probably, if your patient comes in with an occult hernia, I wouldn't go for the CAT scan. I would kind of move forward with an MRI. Is probably actually more helpful for finding the hernia. Optimization to see inguinal hernias. Again, you want to really try to get there with Valsalva. A lot of times for smaller hernias or occult hernias, you're not going to pick them up using CT scans. But if you do it with a Valsalva, you have a more higher sensitivity to pick them up as well. Okay. And that's about it. Thanks for the time. Sorry, I went a little bit over, but Merry Christmas and Happy Holidays to everybody.
Thank you, Salva. Sometimes bad things happen with us, and we can use a CT scan for our favor, but we have to know how to use it. Thanks for the class, and we are all waiting for the book.
Thanks.
The next one to talk today is Professor Carlos Manuel from Portugal, and we're talking about follow-up with images.
Thanks, Rodrigo. It is really a big pleasure to be here. I want to thank Rodrigo for the invitation. I want to thank Conrad for this opportunity to be here. I need to share the screen.
Yeah, it's okay.
Okay. So it is really a big pleasure to be here with all of you. And Rodrigo asked me to speak just about 10 minutes, so I will try to give my main topics, the general topics about what I think about hernia radiology follow-up. This is a picture from my city, Porto. I hope one of these days, next year or in some years, we can meet all of us in this fantastic city. This is the place where the boats arrive to bring the port wine, and these are the port wine caves. So I hope we can meet and we can have a toast all together in some months or some years. I am a general surgeon. I work in Porto. I am working in a ambulatory surgery center. This one, we perform about 15,000 surgeries per year. So related with follow-up, and this will be my topic about the radiology follow-up. It is essential when we have to make some decision to decide what the way we have to give to our patient. And related to follow-up, I put 4 topics. We can make a follow-up when we have a clinical follow-up, if we have any suspicious hernia or any problem that we want to solve, or any doubt. If we have a pain and we don't have any diagnosis, or if we want to make like a differential diagnosis. Also, we can have follow-up radiology when we are planning the treatment of complex hernias, and this is mainly one of the most important situations where we really need a radiology follow-up, the complex hernias. For medical research and for scientific research, of course, sometimes we have to make an archive or a register of our radiology hernias, and related to research, I think it is important we have some follow-up. And of course, we are obliged to use radiology exams for the postoperative follow-up. I will repeat some things of the talk of Salvatore. It was fantastic talk, Salvatore, really, about the CT scan. And related to postoperative follow-up, we can have the situation of the pain after surgery, the recurrence, and the main complications, even if they are early or late complications. Sometimes I don't like to call it complications, because we know that not all situations are really complications. So we call normally intercurrence. I don't know if the word is correct. So some situations about the follow-up radiology, some history. Of course, the herniography is not so used anymore. The X-ray or other types of simple X-rays, and then the ultrasound and the CT scan and MRI are really the topic, the most important exams that we have to use for making the follow-up of our patients with hernias. And one of the things that I consider that is very important is that we have a really good team helping us, working with us. We are not very used to read some exams, mainly CT and MRI, but I think it is very, very important that those of us that work in abdominal wall, that we have good professionals, good radiologists that can help us with our preoperative evaluation, that also they can understand the surgical techniques, because sometimes we know also that the radiologists are not so used with this area, and sometimes we have some difficulties speaking with them and understanding what they put on the radiological reports. And of course, the post-operative evaluation is also very important if we have a good team that can help us to solve what are the normal or the abnormal situations with our exams. This is an X-ray that a patient that I received. He was operated to a recurrence. He was submitted to a laparoscopic approach, and someone put him a plug by tap and fixed it with these tackers. So you see, this is really a strange situation. Another one that I found is the use of the barium studies. I think it is not very used, we don't find it very often, but I found this case study with a Richter hernia that was diagnosed by barium exam. Because we face, when we make our follow-up, we face different situations. We face the situation of the postoperative pain, and we can investigate with ultrasound, with CT, or with MRI. The pain, of course, probably we can also use these three exams, but probably the CT and the MRI will be the exams that will give more value information. The situation of the recurrent inguinal hernia, I think ultrasound is very helpful. If you have experienced soft tissue radiologists, I think they can manage most of the situations. And my experience in Portugal is that we normally solve these problems, or we deal these problems with just ultrasound, sometimes with CT. We are using much more CT now. We are not using very often the MRI for the follow-up. And of course, we have the situation of the groin pain in athletes. I pass this because we are out of time. So we know that ultrasound is operator dependent. Everyone knows it. So it is important that you work with experienced persons. The MRI can be used with dynamic sequences, but I think the MRI has limited value on the follow-up, only if we want to exclude other differential diagnoses. And the CT scan is, in my opinion, also the exam that, as Salvatore said, is the exam that can be more helpful in the follow-up of our patients after hernia surgery, or on the follow-up of a patient with an hernia. Some studies that I found, this one it was interesting, comparing the herniography with the MRI in the dealing of the groin pain. Another one that compared the use of MRI related with the postoperative pain with TAP, and the main conclusion was that the MRI was not so useful. It could inform the group that the mesh was in the right place, there was no recurrence, but it was not so useful for other type of informations. Here is the situation that we can use, for example, ultrasound for the treatment of the pain, the chronic pain, and the ultrasound guide blocks. And we know that the most important situation is when we have to face the most often complications that I put them here, the seroma, the hematoma, the early recurrences, and all these type of complications that we are used to deal. The ultrasound is, as I told you, the main exam that we are using here in Portugal. We have
the changes that you have are really not significant. It's almost nothing that changed. So one important thing when we talk about mesh shrinkage, we shouldn't be talking about what you've implanted and what you see later on your CT scan or imaging technique. You need to do two measurements in time and compare them, and then you can calculate your shrinkage. So in this conclusion of this paper that was published, it's an excellent inter-rater agreement, and for this mesh in intraperitoneal position, we didn't see any shrinkage that was significant. We are now doing a similar study on a small group of patients of 20 in a retromuscular position. I just will show you some of the images that you can create. So this is a patient that had a giant reinforcement of the visceral sac together with a small part of Rives-Stoppa repair. This was probably a patient with a large a suprapubic hernia and also some hernia around the umbilicus. So this is the nice thing that you can ask the engineers to produce based on these meshes. This is a groin hernia. We're also doing a study there comparing glue versus non-glue, and then see how the mesh will either migrate or shrink once again with 1 month and 13 months MRI. This is a robotar. We routinely, not routinely, but very often we do imaging in our large incisional hernia patients after 1 year. So this is a view of such a large mesh placed after bilateral TAR. This is a patient that had a unilateral poli repair. So there's a incisional hernia on the midline, not that wide, so it doesn't need a bilateral component separation, but has a peristomal hernia as well, so which we repaired with a retromuscular transabdominal dissection, an extraperitoneal placement of this mesh. And actually seen this patient about 2 weeks ago. This is the MRI of this patient after this unilateral TAR. You see the rectus muscle. The mesh stops actually on the right side. It's only a Rives-Stoppa repair, while lateral it's combined with a TAR and a poli repair, and you see the colon actually being lateralized. This is a sagittal view. And this once again, another one of the pictures which shows you the colon very nicely coming from lateral, being sugar bakered, but in the retromuscular position. So when I showed it to Eric, he was really, really excited. You know how much he loves radiology. So he's also shouting visible mesh. This is another fascia closure that failed. And this is more an onlay technique in this patient. And you might wonder, is Mersum doing onlay now? But just to show you, this is obviously not an abdominal wall, it's a knee. It was a failed repair of a, how do you call it, patella tendon. How do you call that? I forgot it. So, but they were talking to me, do you have a nice mesh which is a little bit elastic? And we're also going to do MRIs on these patients to show how it looks. So take home methods, which is kind of a stupid sentence because we're all sitting home. But anyway, I would say that visible mesh, I think it can help us. And I think as surgeon, and certainly in the setting of this session, all talking about radiology, that we must try to amplify the message towards companies and people that make meshes, that it might be very valuable for us actually to have meshes that we can see with imaging technique postoperatively. Thank you for your attention. Are you still there?
Thank you, Philippe. That was great. I mean, the collection of lectures that we just heard today, that was awesome. Next level learning for sure. If you have any questions, please put it on in the chat. I have a question for Tachi. Is Tachi here?
He's operating.
Yes, boss. Yes, boss. I'm
hey,
here.
bud. So you know, I'm gonna be totally honest with everybody. I'm not great in physical exam of the groin, especially in females. I have a lot of difficulty trying to figure out, you know, whether or not they have inguinal hernias. So say somebody comes in, referred to your office, female, inguinal hernia. You're not sure if she really has one on physical exam. What is your go-to imaging technique as far as the next step in being able to figure out whether this patient has a hernia or not?
So, my friend, I totally agree with you. Women are tough to decide if they have a hernia or not. I have a very excellent radiologist, a very good echographist, and which happens to be my brother. So when I came back from US in 2007, after starting studying hernia, I said to him, man, you should study this shit. Sorry, this thing. And then he take special interest in that. And today I can tell you that he can, much better than any CT scan, he can describe occult hernias and whatever you have. I totally agree that this examination is totally operator dependent. So in my case, I have him. So I'll start with an ultrasound. I'll start. And I totally agree with you. I always have to do ultrasound in women. Only in the ones that you see the bulge and whatever. But if the complaint is only pain and whatever, I will start with ultrasound. And if I don't have a positive ultrasound, I'll go straight to MRI in my place.
And you would do the ultrasound yourself?
No. In Brazil, you have a radiologist. It's not a technician. It's a physician that performs the examination. So that's why you can trust. You understand what I'm saying? I told this guy, which I told you, happens to be my brother. I told him, man, you have to understand this. And I invited him to the OR, showed him what I need to know. And right now, all my data, they are completely standardized. And the report from the radiology comes always the same thing. He describes everything. The content, the size of the hernia, if it's reducible or no, and whatever it takes, okay? So for me, but this is for me. What happened for him in Brazil, in my place, in Porto Alegre, is that everybody sent abdominal wall disease for him right now. So he right now thanks me for that.
Awesome. Thanks, Tachi. Rodrigo,
Okay.
you got anything else?
I think we don't have more questions, so we can finish this. I want to thank everybody for joining us. We had an amazing time today. I think we don't have more questions because the lectures were perfect and we exhausted the topic about radiology and anatomy. So thanks again from everybody. Conrad?
Everybody be safe. It's so nice to see all my friends here. Can't wait to that everybody gets vaccinated so we can hang out all together again live.
And Merry Christmas.
Merry Christmas, everybody. Be safe.
Merry Christmas.
Merry Christmas to everyone.
Hi, David.
You guys.
Hi, Philip. Hi, Miguel. Feliz
Thanks
Natal
for everybody.
para todo el mundo.
Thank you.
Be safe.
Congrats for the talks.
Thank you.
Bye.
Thank you.